This episode of GT the Podcast is supported by Alcon. This content is supported by Allergan Medical Affairs.
Well, thank you very much for having us here. It's always a delight to come talk about something that we do every day and we're passionate about. I have been putting the XEN Gel Stent in for the past couple of years since it's been available in the market. And like for all of us, it's been a learning curve to get to the point where I am using this. Many of us have become sort of proficient at using the gel stent in different ways and different approaches. But there are definitely some tips and tricks that we have learned along the way that will be good to share. Experiences when it comes to managing things like clinical hypotony and migration or dislocation of the stent. I have here with me Dan Krivoy, and he's going to just also tell us a little bit about his own experience.
Yes, thank you very much for the invitation. I'm happy to share my experience and honored to be with Dr. Smith in this podcast. So I hope it'll be useful to you.
So in taking care of patients that or in surgically addressing patients during the XEN, one of the things that we sometimes see is, especially early on, not so much now with our current experience, is hypotony. Hypotony could occur. And most people would wonder how that could occur, especially just thinking about the fact that the gel stent has been made in such a way that there's such a regulated flow of aqueous, restricting outflow through the lumen. But some of that has to do with the some things we'll talk about a little further along. But in addressing hypotony, we have to remember that many times when we think hypotony, there can be numerical hypotony and there can be clinical hypotony, in which case the patient could have pressures just less than 5. But their vision is not affected. There are no other clinical signs of hypotony visible in the patient's eye. Versus clinical hypotony, when we start to see things like choroidal folds, choroidal effusions, suprachoroidal hemorrhages. These are not things that we do commonly see, but they are possible. It's also very important, the role of anterior chamber depth and best corrected vision with a hypotony. As for me, for most of the times when I do have some hypotony with the XEN Gel Stent, it's usually early on, right soon after the procedure is done. And usually it is very self-resolving, and it resolves within a few days of the implant. Usually within that first week, the pressure starts to pick up. There are some risk factors for developing hypotony as a result of the procedure. Sometimes, depending on how you enter the anterior chamber, if you make the track too short, you could have paratubular flow. That's what I like to call it, which is flow from around the implant. And that could, in that initial period, while the stent is expanding and the sclera is sort of fixing itself around it, could lead to sort of an excessive amount of fluid flowing until the patient starts to heal. Aqueous hormone production is another thing that we see, and I'm sure we all know, Dan, if you want to comment regarding aqueous hormone production in patients that just get glaucoma surgery, period.
Yes, I think you brought up very, very important points, and some of those actually is what differentiates the XEN from a trabeculectomy. The approach to a hypotony, when you encounter it after a XEN, as opposed to the traditional hypotony that we may fear more when you see it in a trabeculectomy, is the fact that the XEN will, by design, have a limited flow, and you have that added security that you're on a usually temporary stage post-operatively that rarely results in the complications that you mentioned in terms of clinical hypotony. And in fact, one of the big advantages over the trabeculectomy, when we talk about all those risk factors that you mentioned, such as the side flow or paraflow, it's if the way I see it is we have a decently long tract through the sclera and a stent that will expand within a couple of minutes. So if there is some additional outflow through there is usually not relevant, and sitting on it and waiting is usually enough.
I definitely agree with that. I definitely agree with that. And if also you can keep that aqueous humor production up. So in instances where their ciliary body shut down, or medicines have not completely washed out, and there's aqueous humor being inadequately produced, that may also give you, even when you don't have excessive outflow, that may give you that perception also. And that also is pretty self-resolving if you treat it appropriately.
Right. Yeah, I think it's one of the expectations maybe that new users have is that the XEN will eliminate the risk of hypotony postoperatively being by design, and is, like you said, not uncommon to find it, but it's a far more benign hypotony in terms of chamber shallowing, size of effusions, duration. So I would not panic when you see hypotony in high-risk cases that you may see, because it's again usually of no significant consequence. Only when persistent, and I have rarely, and I don't know if that's the case with you, I have, they may last longer, but I have not had to do anything to repair hypotony after a XEN, whereas with trabeculectomies, that's certainly more likely to happen.
You made a good point there talking about high-risk patients. So there's some patients that I guess we all have to be sort of more guarded about. Patients who have who are myopic, whose scleras are not so rigid, people who are typically of a younger age. I know those high-risk patients that ordinarily may give you hypotony even with a trabeculectomy. Those are the people to just, watch out for and make sure that you're watching in that initial period while you're waiting for the intraocular pressures to go up. Sometimes we could, surgeons could be responsible by inadvertently creating cyclodialysis clefts. And there's such a thing as an intraoperative flick. I'm sure we've heard about it. For those people who do the ab interno procedure, when you go in and you're starting to retract the needle, it gets to a point where you have to almost relax everything so that you don't have that flick, either sideways or a downward flick. And the presence of a downward flick can actually create a cyclodialysis cleft, which will cause hypotony, not as a result of the gel stent, but as a result of a surgical complication. And that in itself would have to be addressed like we would address cyclodialysis clefts.
Yeah, absolutely. I think we all learned that early on when we incorporated the ab interno placement of XEN. That flick is not a pleasant event, and it's important to be well trained before you actually start doing the procedure. And I'm sure the company and Allergan would help support with that. It is not a pleasant encounter, and it is important to learn to relax the hand by the time you're retracting the needle to avoid that, because that is one complication that you would like to avoid. There are certain situations in which, of course, if the hypotony is prolonged and you have the memory of that event, you have a significant hyphema, you had visible damage to the iris, then it's healthy to suspect that could have been the case as well.
That's true. The interesting thing also for the flick, personally, I place the gel stent both ways, ab interno, ab externo, and there can also be the possibility of a flick. When you do it ab externo, this time the flick is almost like an upward flick, which could actually also increase the size of your entry point through the sclera. So, there are ways around that surgically, apart from relaxing your body, when you're doing it ab interno. Ab externo is just that actually a conscious depression as you slide out so you don't have that upward fleek, because incisional tear leaks from around your incision, whether it's your paratract or from the conjunctiva, those kind of things can cause hypotony as well. In the end, when we have hypotony, we do have to treat it. So it's important to look at some of these things we talked about, whether it's a side flow or paraflow issue, aqueous humor production issues, incisional leaks, intraoperative flicks, or high-risk patients, and try to find out what the problem is. It's good to make sure that if there's a causative agent that's addressed, we have to look for a cyclodialysis cleft. Of all of these things, that's the one thing that may have to be actively addressed. But cycloplegia in a patient, like we would treat any hypotony patient, or AC reformation or refill, I've never had to do that either. But the aim is to for the most part, just a little atropine and a steroid drop, increase in aqueous production usually addresses the problem. Any recommendations for cyclodialysis closures?
Yeah, I think that you mentioned the treatment at this stage in this situation is mostly conservative. I wouldn't panic. I think I may add one of the tips I can give new XEN users is that when they make the incisions and they're aiming the stent superiorly, they have to make the incisions and aim to a location they feel comfortable doing with their hands relaxed. The anatomy varies, the orbits, the exposure of the superior globe varies from patient to patient, and we're very dogmatic when we start about being X degrees away from when you're going to implant it. Then it has to be nasal. You want to shift superior. So I think a way to minimize this is to find the position and the location where you're going to insert it that you feel comfortable and relaxed, so that when you let go on the traction, you avoid that flick. But in my experience with regards to managing clefts in general is that you have to be conservative. You can wait a long time. You probably should not intervene almost before 2 months, even if you're concerned about maculopathy, because it comes back to the distinction we made originally at the beginning of the podcast, whether it's numerical versus clinical hypotony. You do have to intervene if you have clinical hypotony. You do not necessarily have to intervene if you have hypotony. And being conservative pays off. Usually, you manage it medically, cycloplegia, and watch out for that pressure spike that may occur once the clefts seal up. That we all get that call late at night. But for the most part, it is a conservative management. And when we address how do you surgically repair a cleft, it has to be that has been long enough with clinical hypotony that you really intervene. And then, of course, it's a challenge to do it. And that's why there are so many different ways to do it.
That's so true. So true. So in summary there, just looking at the hypotony issues, I think if we follow the technique, if we have good technique, we're able to avoid this, making sure you have a long enough track where it's not too short and not too much flow, relaxing when you should, watching the high risk patients and making sure to stop drops and to just treat appropriately with steroids. So good technique usually helps to overcome this problem. Let's move on to the other discussion that we're going to have, and that discussion surrounds migration and other malpositions or dislocations of the stent.
Yeah, this is something that we encounter as a challenge, especially at the beginning. And I would say that with regards to migration and dislocation, I mostly see it when the stent is inserted ab interno. And it is my impression, and the best tip I can give to new users is that the migration is usually towards the anterior chamber, and it has to do with the stent being trapped on a thick tenons. If you encounter that when you're inserting it ab interno, the stent tends to go back into the anterior chamber, First, it should be easy to move. I find that with a non-tooth forceps transconjunctivally, you can slide it back and forth, usually easily, and it should be easy. If you are having trouble pulling it out of the anterior chamber, you have to think that the tenons, the tip of the stent is strapped on tenons, and it's that force that is driving it back. That's where I would recommend consider needling the stent transconjunctivally to make sure that you're not leaving any tension, because even if you manage to reposition it in the operating room, you may have the unpleasant surprise that at the slit lamp the next day, it had migrated anteriorly. So it is important to make sure that that you place it above tenons, and when sometimes that's not possible because younger patients or some have thicker tenons, that the stent is free of any attachment. That will minimize migration. I have to say, I don't know about you, Dr. Smith, but migrations externally are not common. It's mostly that they try to go back in when you insert it ab interno.
You know, I agree with you. It's interesting, though, that I have seen some migrations that have happened a little further along. I actually had one patient who was really myopic, and he did well for a while. And then I decided to go needle him when he started sort of shutting down his bleb. And even at that time, almost 6 months out, so I go ahead and I'm needling him. And as I'm needling him, I actually see my gel stent start to, so it must have curled up somewhere there subconjunctivally and start to show up in the AC a little longer. But he had such a gorgeous bleb, and the bleb was still functional. And there is a longer segment of the gel stent inside the anterior chamber, but it was fully functional in that case. So it does happen sometimes in people who are really nearsighted. They maybe because their sclera is not so rigid, and if they go, rubbing their eye or something like that, you could actually have that happen. But for me, in that particular instance, his pressure is still like 9, 10 with the most gorgeous bleb. So I haven't had to intervene there. But sometimes we do have to do something about that.
Yeah, it's very interesting. You mentioned that curl that you see with the stent is a red flag telling you there's tenons involved. And when you leave the OR, try to avoid that, and getting comfortable needling the stent is important for every XEN user, because that curl says to you it's going to move. Now, on the other hand, what you mentioned is very important, and I share that experience. It might migrate if you have a functioning bleb with well-controlled intraocular pressure. It does not matter. It's of course, if it's in a position that may lead to trouble, cornea or iris, I understand. But for the most part, you do not have to have that 1 millimeter in the AC, 2 interscleral, through in the other subconj. If it moves, but it is doing its job, and you have a bleb, then some migration may occur, and again, that may not be clinically relevant.
There are times when we have to go and do something. Of course, if the implant is somehow touching the cornea and there's causing any corneal issues, or it actually drops right into the anterior chamber, in which case the entire gel stent is in the anterior chamber. And then, of course, we'll have to go back at that point to take it out completely to the operating to reposition it or place another one. But for the most part, depending on how functional the bleb is, observation is definitely not a bad option. Have you had to manipulate at the slit lamp?
Yes, that's in fact, you can slide the stent back and forth at the slit lamp, and it's fairly easy to do and very well tolerated by the patients under topical anesthesia, surprisingly. Mm-hmm. That's also, I would say that even in the operating room, during the implantation, focus on placing it in the right position, but not so much on how much you have in the intraocular portion or the extraocular portion. You want it to work, and you can always, after deploying the stent in the operating room, adjust transconjunctivally like you would on the slit lamp with a non-tooth forceps. Early on is easier than later on, obviously, and that's usually when you need to do it. And if at the slit lamp, and I've seen this, especially with ab interno, that you can easily reposition it, and almost in front of your eyes, it would slide back in. That's telling you need to needle the outlet of the stent. And that can certainly all be managed at the slit lamp without having to go back to the operating room.
That's true. That's so true. Needling and getting comfortable, being able to needle. If you feel it's hung up on Tenon's, needle right there on the table before you leave the operating room. If you're not happy with position, especially those first few days early on, you can manipulate at the slit lamp. And if you need to needle then to free things up, I think it makes for the best outcome for the long term. Recently, we had a publication in Current Trends in Ophthalmology called Navigating Challenges After XEN. And it was really to just look at the most common adverse events after XEN, understand pathophysiology, and give us insight into how we could have prevented them and how we can treat them. And I thought it was a really good paper. Danny, have you had a chance to read that, and how do you think that will be helpful to our audience?
Absolutely. I actually found the paper to be very useful because it very much goes to the point on each one of these complications that we're talking about. And it's very concise. You don't have to browse through it, but when you encounter this, it has valuable information that has been compiled on how to best deal with these challenges. I would certainly have this handy if you're going to be implanting XENs.
Well, it seems like we've had some really good discussions about some of the things that we've encountered, taking care of patients that we've implanted XEN gel stents in. It's always a good thing to be able to share one's experience and to find out that you're not alone in the things that we face having to take care of patients. If I had to leave you with one thing is follow technique and be patient with yourself.
That's right. Yeah, I would just finish saying that incorporating new techniques is always intimidating, and it's a challenge. But these are new technologies and implants that do benefit our patients. And these stage in which you encounter these, you certainly get more comfortable. And I would encourage everybody to persevere and not be turned off by some of these findings, which you may not be familiar with, but are certainly something that you can overcome. And thank you again for having me. I appreciate the opportunity.
Well, thank you.